Very good. So I don't know, I think you can start. We have a
Sure.
good number, yeah.
Okay. Welcome everyone to session 4 of the Oxygen Therapy and Critical Care case-based series. Today's topic is escalation to a higher level of care, and the session will be led by Dr. Eugene from the Institute of Medical Education and Global Health. We'll also be joined by several co-panelists, including Dr. Jean-Paul from the University of Rwanda, Dr. Celestin from the Centre Hospitalier of Butare University, and Dr. Alain from the University of Rwanda. Before we begin, we do have a couple of points of housekeeping and Project ECHO etiquette. So our programming is based on a foundation of love and respect. Please respond kindly rather than react if you disagree with something that is said. It is everyone's responsibility to keep this webinar a safe space. We will be using the chat function for question and answer. Please send all questions through the chat box and feel free to introduce yourselves. If you have sufficient bandwidth, please turn on your video and position your webcam effectively to show your face, if alone or to capture the whole group. If your internet connection isn't that great, keeping your video turned off might help with that. If you have any IT issues, send a message through the chat. The session is being recorded and your attendance is consent to be recorded, so thank you. And please be mindful of infection prevention and control. Try to limit the number of people joining from one gathering place and practice physical distancing. And with that, I'll turn it over to Dr. Eugene to begin.
Thank you very much, Arana, for the introduction. And thank you everyone for joining us today. So I hope we'll have an engaging discussion. So before we start, I would like also to ask Jean-Paul to make a few comments and then we start.
Hi, everybody, and good evening. I don't know if I'm going to respond what Eugene asked me of making a few comments. I didn't catch well which comment. Is it the last session or for this session?
I wanted you just to say a few words for introduction. And
yeah. Just I'm happy this evening to be with this team, and I hope this session will be fruitful and everyone will enjoy it. Thank you.
Okay, very good. So the plan for today, we're going to discuss about the rapid response system and also about critical care outside ICU. So also we'll discuss about the availability of your certificate at the end, and we'll discuss also our plan for CPD. Okay, so Arana, can you increase the size on the screen, please? Thank you. Yeah, I think that's good. So here are the objectives for today. So the first objective is to develop decision-making competence about when to admit patient to hospital using triage protocol and hospital admission criteria. To define mild, moderate, severe critical illness. Aaron, I don't think we are on the planned session. So we can, maybe I can share my screen to show you what we are supposed to cover today.
Sure. Are you looking at part 5?
part 4.
Part
Part,
4.
part 5. Part 5.
Part
Yes.
5. Okay,
Yeah,
okay.
that's
Oh,
what.
I got it then. Sorry.
Thank you. Yeah, this is what we were supposed to cover today. Sorry.
Okay.
Yeah, so first we need to define the critical care continuum, and I hope everyone has read the article we shared about continuity of critical care. And then we need to understand the SPO2 goals for oxygen therapy, and we'll be able to define and utilize quick SOFA, modified early warning sign, and quick COVID severity index scores. We'll be able to outline the life-threatening signs and the symptoms, indicating timely critical care as needed. We'll be able to identify the key personnel that offer timely critical care, and we'll be able to create, to discuss about how to create and review the rapid response team policy document in our institutions, and we'll be able to know how we can use scenarios to identify gaps and areas for need improvement. So before we move, I would like to ask you to write in the chat if you have read the article, the 2 articles we shared on WhatsApp. The one is about continuity of critical care. The other one also was about the implementation of the rapid response system in one hospital in the US. So you please put in the chat if you got a chance to read the article. You can wait for a few minutes. Okay, are you writing now? Okay. It seems like most of the people, they didn't read the article. Maybe I can just summarize my take-home point. And our co-panelists are welcome to add something. So for the first article, it was the article written by Jean-Louis Vincent in the Journal of Critical Care in 2019, discussing about the continuum of critical care. So he defined critical care in 3 phases: pre-ICU, which include the pre-hospital, and then in-hospital pre-ICU, and then the ICU, and then the post-ICU. But for our focus, we can focus on the in-hospital pre-ICU, where he was recommending that it's time to implement the rapid response system, modified early warning signs, and also to provide safe transfer to the ICU. And he said that better care before the admission to ICU and after the discharge from ICU contribute to the good outcomes. Also, he noted that delay in admission for 1 hour, it increased the risk of mortality by 1%. So the risk of in-hospital mortality is increased by 1% for each hour in delay of admission. And also the risk of dying in ICU is increased by 1.5% if you delay 1 hour of admission. He said that early identification of deterioration on a general hospital ward can help to reduce the need of transfer to the high acuity unit. reduce hospital length of stay and the cost, and improve the survival rate. So that was the summary about the continuity of critical care. It's not like ICU as a separate unit, but it's identification of the critical illness throughout the hospital course and then at discharge. So we may think about how feasible is that in our context. For the second paper was the paper written by Jeremy and colleagues in the Journal of Critical Care in 2011. So he was showing the implementation of the response system in one tertiary hospital in Massachusetts General Hospital in the US. And he showed that the team composition was including the doctors, nurses, and the physio, and the common activation of the team was using clinical judgment and also early warning signs and quick SOFA. The common triggers include seizure, hypoxia, and hemorrhage. Common intervention included intubation, oxygen therapy, suctioning, anti-seizures, fluid, using of nebulizer and vasopressors. The most of the people were disposed in ICU and observation room, telemetry, and ER. So he showed that implementing the rapid response team decreased mortality by 11%, mainly in the general medicine and the surgery department. It decreased the out of ICU codes by 130, which was good. So those were the summary of the two articles I shared, which will be relevant for the discussion. So it's a lot of information. I would like to pause here and let my colleagues make some comment. Then after that, you can ask questions before we go through the discussion. Jean-Paul, do you have anything to add?
Actually, I would like, if possible, to hear if there are comments or questions regarding to these two papers. Maybe that would give me more direction. In fact, you went through and you gave us a summary, which is comprehensible and relevant. If maybe someone is having a question or clarification, then I can go ahead.
Very good. Yeah, if you have a question, you can put the question in the chat. So we'll give you maybe 30 seconds. Then after that, we can go through the discussion and we'll answer the question as we go. Okay, people are very quiet. Alana, let's go to the next, next slide. Very good. Let us start with the practice change 1 to define a critical care continuum. Here is the first question. Which of the following are considered the critical patient care? 1. Early recognition, assessment, and decision-making for deteriorating patient. 2. Rapid and timely intervention for patient at risk of clinical decline. Identification of clinical warning signs prior to cardiac and respiratory arrest. Providing expert assistance in response to concern for patient status, or all the above. So you can choose one of these answers and put the answer in the chat. Which of these 5 is considered critical patient care? Okay. Maybe they need me to point someone because people are very quiet. So Emil, what do you think? Okay, I see some of the answers coming. Okay, Raban said all the above. Okay. Yeah, Raban is correct. So all the above actions, Oscar, yes, all the above actions are considered critical patient care. So you recognize the problems, you provide intervention, you identify warning signs, and you provide expert assistance in response to concerns for patient status. Actually, this number 4 is where the discussion for today will be focused on the rapid response team. Okay, let's continue. Alana, let's continue. Okay, yeah, let's click on this second one saying, how would you define critical care? So this is the article I was talking about, and I think you have access to the article through this link, but also we shared that on the WhatsApp group. I don't think we need to spend a lot of time about that, maybe, but the key message is that critical care is not the ICU. Critical care starts when the patient is sick with early signs, and then it may start even when at home, when someone is very sick. Then the pre-hospital people, in our context like SAMI, they go to see that patient. Then they bring the patient to the emergency room. That's also part of the critical care. When the patient is sent maybe in the ward, that can be also part of the critical care. If they become hypoxemic or they have hypotension, that also will be part of the critical care continuum until they go to ICU, they are managed in the ICU, and then also they are discharged from the ICU, and they are sent maybe home or in rehabilitation. So that was the article. Before we move, I don't know if Are or Jean-Paul has something to add. And Arana has shared the link to the article for your review in the chat.
Thank you, everyone. Sorry, I was a bit late. So as you said before, we go through it and we try to share even our own experience. And I'm so happy that this subject was brought out. It's something which is so needed in our context. And sometimes we say that we have few ICUs, but as you said, ICUs are not only housed. Their intervention from down from where the patient is founded. That's why I think today we get a great discussion.
Thank you, Alain. Jean-Paul, any addition?
Thank you. The addition what I can add from what you said is that I want to emphasize this word of critical care. All of us, when we hear critical care, all of us, the first thought is ICU. So actually, the critical care doesn't mean ICU. The critical care is a critical condition where a patient is in a critical condition. From there, the care should start early as possible. And then the continuity, the care you start from there, you meet a critical patient up to the ICU, as as we saw it in the article. It's a continuation from the starting point where you meet a patient who is in a critical condition, you start the basic care up to the ICU. That's my supplement.
Okay, thank you. So Arana, let's go to the case and then we'll discuss through the case. So here we have a case. So the setting, you are working in a rural hospital. So the nearest teaching hospital or the hospital of ICU is about 120 kilometers away. So but the roads are closed today due to inclement weather. So this morning you are on medical ward rounds and you saw a 54 years old male, patient with history of coronary artery disease, hypertension, and type 2 diabetes, admitted to inpatient ward 3 days ago with COVID-19. So his chief complaint is shortness of breath. On rounds in the morning, you noticed he was slightly tachypneic. The respiratory rate was 27 cycles per minute, but he's still speaking in full sentences. So he requires oxygen by nasal prongs, 3 liters per minute. He has a few crackles on the lung exam. His exam is otherwise unremarkable. So the vital signs, the respiratory rate is 27, as we said, temperature 37.9, the heart rate is 95, the blood pressure is 107/59, and SpO2 is 92. Okay, let's go down. So what is your interpretation for this patient signs in the physical exam? You can put that in the chat. Is it a normal physical exam? Are these vitals normal? Yeah, you can put your summary of your interpretation. Okay, while waiting, you can go down to the next slide. Okay, people are very slow to respond. Okay, so just keep in mind what you have seen. Okay, yeah, Emma said the vitals are not normal. There's tachypnea, low-grade fever, and hypotension. That's a good summary. Oscar said tachypnea, low-grade fever, mild hypoxia. Okay, that's very good. Let's continue and see the change. So despite your 3 liters per minute oxygen by nasal cannula, 2 hours later, the patient SpO2 decreased to 86. When you arrived, he appeared to be more tachypneic and is working harder to breathe. He can only speak 2 to 3 words at the time. So as you see, the patient is deteriorating. So what will be your goal for SpO2 in this adult male patient? Which intervention should be taken for this patient? Remember, this patient has history of coronary artery disease, diabetes, and hypertension. So what will be the goal of SpO2?
Yeah, unmute.
Okay, you can just write your goal. Okay, thank you. In the respiratory distress, need the respiratory support. That's good. Maybe people can try to be more specific. What are you going to do? How much oxygen will you give? And what will be your target? That's what we are looking for. I don't need to spend much of the time explaining the target because we spent like 2 sessions on oxygenotherapy. Okay, while we are waiting, you can go to the next slide. And you see the next vitals. The respiratory rate is increasing to 32. The temperature is 39. Heart rate has increased 119, 115. And the blood pressure is 83, below over 55. SpO2 is 86. Okay, I see someone saying increase FiO2 at least above 94 using non-rebreather face mask. Okay, mask with reservoir, that's good. Target 94. Okay, that's good. Okay. Okay, yeah, we'll come back to that. I think that those are good targets. But for the purpose of this teaching, they were recommending to have a target of 96%, especially that the patient has coronary artery disease. Okay, Jean Leonard is saying there is a risk of the respiratory arrest. Okay, very good. Those are all good thoughts. Okay, so keep the patient in mind. Now we're going to go to the next discussion about using the clinical scores. So we need to define quick SOFA, modified early warning sign, and the quick COVID severity index scores. So here is the question. Which of the following are possible differential diagnoses for the signs of the symptoms for our patient? Yeah, you can put the answer in the chat. Do you think this patient has 1, sepsis, SARS, respiratory failure, ARDS, or all the above? SARS is syndrome of inflammatory response syndrome. Okay, SARS is systemic inflammatory response syndrome. ARDS is acute respiratory distress syndrome. Okay. Yes, Jean Ronald is saying we may need intubation in the fluid because of sepsis, and Marbury is saying all the above. Okay, and I would agree. Okay. Maybe Alain can help us to discuss about quick SOFA, and then Jean-Paul will help to discuss modified early warning signs, and I will also discuss about the quick COVID severity index. Alain, you can go ahead with quick SOFA. Yeah, maybe Alana can help to click on that. What is quick SOFA? Alain, are you there?
Yes, I'm there. Thank you. Maybe some of us have already heard about this quick SOFA, but I'd like to first talk about it is SOFA. This is there are some people who call it sequential organ failure assessment, but some books it is written sepsis, but it is sequential organ failure assessment score. So by quick, there is what we call SOFA and what we call quick SOFA. Here we talk about quick SOFA, which has three main components. The first one we go with respiratory rate. I don't see this moving, but maybe let me try to follow this rule. Okay, the first one here, they are talking about the consciousness of the patient, which is alterated. So here they mentioned that the GCS should be below 15. Sometimes we go around 13. So if the patient has a decreased GCS, Glasgow Coma Scale, we talk about we get one component. And if, remember, normal patients should be breathing around 12 to 20. And if he's breathing more than 22, we get the second component. And for the blood pressure, we go with the systolic blood pressure. If the systolic blood pressure is below or equal to 100, this is the third component. So those three components, you see how much it is easy to consider them, and we have access. We can control this without too much need. I mean, you don't need maybe invasive monitoring. You need only a cuff, non-invasive blood pressure, the respiratory rate you can count by yourself. The GCS, it's easy if you know the three components of the GCS. You will do it by yourself. So it is something you can do in hospital or in recreated places, and it gives you an indication on how severe the sepsis is. And with this, maybe shall we talk, Eugene, shall we talk about the outcome of the quick SOFA, or you could talk about it?
No, go. You can go ahead.
Okay. With this quick SOFA, it gives you an idea of about the mortality. I don't know, is this application give the mortality, the idea, I mean, but if you go with the 2016 article, it helps you to know that around 10% of people with those three components has the risk of dying, 10%. So I don't know if this tool is helping on that. Okay. So this is what is coming. So if this is 3 point, here it is written that with 3 to 14-fold increase in hospital mortality. So this is, you see how much only those three components can give you an idea of how much it can become bad if you have all those three, those three components on one patient. I'm not sure if any question on that, or we are clear.
Yeah, if someone has a question, they can put the question in the chat. So, but again, we have to remember that this can help to predict mortality and the ICU admission. So especially in our hospitals, if you go to the emergency or on the ward, then you calculate the quick SOFA, you see it is more than 2. Then you start thinking about, oh, maybe this patient needs to be transferred to high care. Maybe I need to transfer to a teaching hospital or a referral hospital. Maybe this patient may need ICU. So it can help you to predict and plan ahead. Would you agree, Ade?
Yes. And this is more easy than the SOFA, because the SOFA asks you main lab exam, which can be done everywhere. But with these three components, you can react as quick as possible.
Thank you very much, Aaron. Let's see if there is someone with any question there. If there's any question in the chat. So in the meantime, we can go back and Jean-Paul can start talking about the modified ironic sign.
Thank you, Ade and Eugene, for the previous one with the quick SOFA. I like your comment you mentioned about this score, or why they put this score is just you are looking at the deterioration of this patient And this also will help you to predict mortality, especially in sepsis and septic shock patient. So the modified early warning score for clinical deterioration, as you can see, it's a let's have an example in order to understand it well. You are throwing a patient in a medical ward, or you are having a patient in front of you, and you are not sure if this patient is becoming worse, his condition is becoming worse. So the goals or the purpose of this modified warning sign is just to predict or to see if my patient is it deteriorating or my patient is it improving. So there are a couple of parameters that you are going to look. It's the vital signs. Yeah, the first one is blood pressure, where you are looking about historic blood pressure. And as you can see on the screen, there is the score 0. Once the historic blood pressure is, you can see in 100. When it's +1, +2, +3, and even +2. So you see which BP, historic blood pressure you have, and then you score. And again, you go on heart rate. You see which heart rate my patient is presenting, and then you score. And you see the respiratory rate, then you score. And again, you go on temperature, the body temperature, and then you score. And then you go on mentation. As you know, in adult, we used to use the GCS, but you here use AVPU. Mostly is common in pediatric patient, but even in adult, it's easier to see if someone is alert, is responding to voice or pain, or is unresponsive. Then you give the score. If the purpose of calculating this score is that when you have a patient who has a higher score, that means this patient is deteriorating and needs special attention and need transfer in the appropriate. If you are in a district hospital, if you are in a health center, the patient needs transfer to district hospital. If a patient is in a district hospital, need to be transferred immediately to referral hospital. Again, after having that, the patient is having a high score. It's another indication of involving the medical or the treating team to come together and find a clear management plan while you are organizing the transfer. Even if you are in a referral hospital, you can still calculating this score just to have an idea of if your patient is becoming deteriorating or is in a moderate condition or is in a normal condition. This score, some hospitals or some institutions or some centers, they have been modifying it, or they have their own score. But remember, all these parameters we said, blood pressure, heart rate, temperature, or mentation, all these parameters should be there in order to predict my patient, is it deteriorating, my patient, is it improving. So if there are a question regarding to this, I've come to explain, I will be happy to go ahead. So again, you add this patient is septic or is having COVID.
Thank you very much, Jean-Paul. We can see if there is any question. But also, maybe Jean-Paul, remember, we have published one article about our obstetric warning sign. I'm going to share the article on the WhatsApp group, and Alana will see if she can be able also to share maybe on this in our chat, because it was technically difficult for me. But we published one article showing that by having high score on adult obstetric warning sign, you increase the risk of complications by 4 times. So including PPH and eclampsia and sepsis. So we tried to implement that in the 4 hospitals. Jean-Paul, do you remember?
I do remember.
Yeah, so I'm going to share that on the WhatsApp and then we can continue. But also questions and comments are welcome. Okay. Yeah, the article is already shared on WhatsApp. And then we will discuss about the COVID Severity Index. Okay, Alana, can you go back to our slides, please? Thank you. Okay, thank you very much. So we can click on the quick COVID Severity Index as well. So yeah, again, as you can see, this index will help you to predict the 24 hours risk for critical illness in a patient admitted at the emergency with COVID-19. And you are just looking on respiratory rate, pulse oximetry, and also the need of oxygen. As you can imagine, the more oxygen you need, the lower the saturation, and the higher the respiratory rate, the more risk you have. So as you can see, if you have a 0 score, you have only 4% chance to have critical illness at 24 hours, defined by requirement of oxygen more than 10 liters and or death. So let's Alan, let's click on the highest score for all 3. So as you can see, if you have a respiratory rate above 28 and you have a pulse oximetry below 86 and you are needing oxygen more than 6 liters, your chance to have critical illness is 57%. So remember, our patient had a respiratory rate of 32, pulse oximetry of 86, and oxygen flow of 3 liters. So you can click on oxygen flow of 3 to 4. Arana, yeah, thank you. So our patient has 11 points, so it's a high risk group. So that's how this like COVID Severity Index can help you predict the risk of critical illness. And in our context, you will decide to transfer the patient, for example, and then you will be prepared ahead. Okay, so let's go back to our main slide. If there is any question, you can always answer the questions. So I think for the next discussion, it's the most important part of the discussion. So because we're going to discuss about the rapid response system, so what do we need to achieve? We need to outline the life-threatening signs and the symptoms indicating that patient need timely critical care. So remember our patient again, there is a change in our patient. So the patient suddenly loses consciousness, new vital signs are obtained for this patient. Okay, so and then we can see the change in vital signs. So the respiratory rate is 40, the temperature is 39, the heart rate is very high, 147. The blood pressure is very low, 3/25, and SpO2 is 66%. So I will answer that. This question is asking which vital signs and the clinical exam findings require immediate intervention. And I think everything needs immediate intervention. Maybe the temperature is still okay, but the heart rate, the BP is very low, so we need immediate intervention. Um, so the next question is, which intervention do we need to do? Maybe you can put your intervention in the chat. So what will be your approach? Which intervention will you do? Okay, here is some examples. High level of care, increased oxygen therapy, more frequent monitoring, ongoing resuscitation, airway management, or all of the above. So we made the question easier. Okay, all of the above. Okay. Yeah, remember for us, like for the anesthesia team, we always approach this patient with A, B, C, D, E approach, and we manage each problem as we go. So we see if the airway is patent, if the patient is breathing, which the breathing is very increased, we give some oxygen, and then we give some vasopressors. We decide if we need intubation because of impending respiratory failure, and then we will transfer the patient to a higher level of care, probably a teaching hospital in the ICU. Okay, let's continue to the next question. Does your hospital have a rapid response system? So I would like to know, it will be interesting if everyone can write in the chat if you have a rapid response system. You can say yes or no, and then we'll continue after 1 minute. I give you 1 minute for everyone to write that, because it's important for us to know our baseline. Okay, very good. Okay, so while other people are writing, Amy, if you have a good internet, you can unmute yourself, Amy Nihavos, and tell us your experience. Who is on the team? How is the team called or activated? Is there any quality improvement going on? So you can just share your experience. Amy Nihavos, and then Carissa, and then we'll continue.
Can you repeat the question, sir? My experience, what I have taken this course,
I mean your experience with the rapid response system at your hospital.
One day I was in, we have done, one day we have done C-section. Then we send patient on post-op. Then after 6 hours, patient, they called me, patient is starting deteriorated. When I put in a pulse oximeter, the patient is 32, 33 saturation. She's trying to, she's not to breathe well. Then, but when I arrived, I put patient on oxygen, but it is not improving. She's not improving. I decided to come to initiator. Immediately. Then I intubated. After intubated, and I put on oxygen. After after intubation, patient is improving well. She's saturated 98 saturation. Even sign vitals of heart rate and the blood pressure started to improve. That is my experience. I wanted to share it with you.
Okay, thank you very much. So Carissa, so I would like to hear from you your experience in a respiratory, in a rapid response system or rapid response team. So who is on the team? How do you select people to be on the team? And then who is activating the team, or who is making the call? How do you train those people? And then if there's any quality improvement, just those three questions. Who is in the team? How is the team activated? And how is the quality improvement support? Carissa, are you there?
Thank you, sir. Here we have previously we didn't have the team, but since COVID started, the hospital make the rapid response team, but they forget to put some people who was on who was very, very important, like anesthetist. Then once they had a case, they call us and they notified that they don't put some key elements. Then they started to put some of us and like anesthetist on the team. Some people was previously we had the station team who on the, for example, for critical care, but the last response team was they add some people on who was in the resuscitation committee like anesthetist, but for now they get that experience that they forget to put some key elements. Thank you.
Okay, thank you, Carissa. I need to make this practical before we go into theory. So for me, in my experience, like in my hospital where I work, so let me give my understanding of a rapid response team. So first, there is a difference between a rapid response team and a cold team or a resuscitation team. So the big difference for me is that the rapid response team is called before the patient has deterioration. So you are called maybe because someone has just hypoxia of 89, or you are called because someone has hypoglycemia of maybe uh, 3.8. The patient is not yet deteriorated, or someone had one episode of seizure. So then the rapid response team may be called. So most of the hospital, it can be the same team as the resuscitation team, but once they're called the rapid response team, they don't go as fast as the resuscitation team, and maybe they don't go with the whole resuscitation cart, but you have the expertise. So people will just go and evaluate the patient and provide initial management and decide if there is a need of the ICU. So, and that's why it is important, because once you do that, you minimize number of patients who would need to be admitted in ICU or who would need CPR. So it's before someone needs CPR or needs admission to ICU. That's the first big difference. So, and then who would trigger the system? We'll see that in details, but usually anyone with the training to know that someone is deteriorating. So it may be a nurse, a family member, the patient themselves. In some advanced hospitals, there is a button you can push. People will get alarm, then they know they are called, or there is a pager system, or you just call a number, then people will come and support the patient. So the common symptoms and the reasons why we would need to activate the team, I shared the article, you can go in details, but mostly the common issues: hypoxia, hypotension, tachycardia, arrhythmia, seizures, airway obstruction, things like that. So in the response, most of the time we will treat that by providing basic oxygen support, giving vasopressors, fluid, until some of the people need to be intubated. And the disposition, you may keep the patient in the ward, you may have a small observation room, or you may have the patient to be sent in a high dependent unit or critical care. That's my summary of the difference between um, a, a rapid response team and the resuscitation team. So before we move, I would like to hear from um, Alain and Jean-Paul their experience. Let Alain give also gives his experience, and then Jean-Paul. After that, we can continue.
Thank you so much, Eugene. So first, we talk about our hospital. As you said, we have both those two teams available. But nowadays, this rapid response team has been, I mean, members. We got more members because we've been exposed. Or it was one of the places where we were receiving people with COVID. But apart COVID, we used to have the resuscitation team, which were with all members having a training in resuscitation, although it was not at the same level. But nowadays, as you said, with the rapid response team, we have even people from working at the gate able to intervene or to talk or to share what is happening. So the hospital now is no longer only from inside the hospital, but from gate, from people working to the working in ambulance, or from people from on emergency on EMS. We are able to talk. So we have a special connection, which doesn't need any special, I mean, not calling, but it's a kind of internal connection, but which can go more than, which even people who are around 10 kilometers can access. So it's easy because whoever is around, whoever is needed can be contacted. And if you found that our hospital is saturated or it's full, we can also call other people from other hospital to help us. So I understand some people, some hospital are combined at the same time, the resuscitation team and the rapid response team. But the resuscitation team is called when we have crash card or we have those called, but the rapid response team is involving even people on high command or deciding people who are not working on field, but who also help us to plan. And I think also planning is something important. And it's something important. Yes, thank you.
Thank you, Jean-Paul. And we have Wilson speak as well.
Yeah, thank you. I'm asked to talk about rapid response team in my as experience of my hospital. I'm working at Butare University Teaching Hospital. Recently is now becoming COVID National Treatment Center for the Southern Province and Eastern Province. But before we used to have this resuscitation team. Resuscitation team is being contacted, but the key component is that in each department, in the hospital department, pediatrics, surgery, internal medicine, or wherever, each department, those people who are working there, nurses, doctors, they have the basic training in resuscitation, basic courses in BRS, SRS, and PARS. So not everybody, the aim is to have everybody trained, but at least you can find 2 or 3 people who have been exposed in such training. And each department, it has one representative of the department who is a member of resuscitation team. So whenever there is in the ambulance department, everywhere there is a representative. Some people have been exposed on this resuscitation course. So whenever there is a problem, they start. If a patient collapsed in a medical ward, in the past, they used to call the anesthesia team, because the anesthesia team, they are the one trained in resuscitation. Until you came there and you start, there is no oxygen, there is no ambu bag, there is nothing. They are waiting just the anesthesia team to come. It was there in the past. As nowadays, the system is improving. If a patient crashed in any department, they start the station. The nurses, the doctors, they start the station while calling the station team. This is something that we are appreciating, because the people on the ground, if a patient collapses, they can start while calling the other team members to come to help. That's the experience that we are having in Butare. And I guess in the most of many hospitals in Rwanda. Yeah.
Okay, thank you.
Can I ask you a question to my colleague from Butare? Yes. Do you have a rapid response team, especially not the resuscitation one?
No, we don't have. It's a resuscitation team, resuscitation committees.
Okay. Yeah, maybe by the end of this discussion, Jean-Paul also will think about the ways, if we think if the rapid response team is needed and the ways that can be implemented. Um, because I think it has shown really a good improvement in mortality and morbidity in comparison to a regular system where the patient is seen after deterioration. Because again, the goal of the rapid response team is to see the patient before there is a need of the CPR, things like that. Arana, let's go to the next discussion. So as you can see, we're going to discuss about the key personnel who should provide timely critical care. So what providers should respond to this patient deterioration? So you remember our patient has hypertension, has tachycardia, has also tachypnea. So who should respond? Maybe you can click on that and see what they propose. But we have been discussing that. So it's a multidisciplinary team, including people can manage the airway, people can provide resuscitation. In some hospitals, that include the respiratory therapists and also nurses, and that can also include pharmacists. So maybe people will go through, we can go down to the next question. Okay. What are the stakeholders that are needed to implement a rapid response system? We can click on that because I think this is very important for people or who the hospitals which don't have the rapid response team. You can go down. Okay, yeah, you can stop there. Go up a little bit. We click on the rapid response team structure, which is, 10. Yeah, so I think this is good to see what I mean. So you can see we have the clinical treatment, so which will include people who are activating the team and the responders. So, but also you have the support mechanism, which will include two teams, administration and quality improvement. So actually those are the things you need in order to be, to have a rapid response team. So I don't know if you see if it is clear, but you need to start by having the rapid response team, including the activator and the responders. And then after that, you will need to have the support from the administration, because if you need the equipment, development of policies, things like that, and also need the quality improvement team to help measure the success of the team. So you can easily compare the outcome of your resuscitation, the ICU admissions, and then in the comparison to before the initiation of the rapid response team and after. So I don't know if it is clear. So if there's any question you can ask, we can go back, Arana. Thank you. Okay, go up a little bit. Yeah. So what are the documentation which should be done? Because if you are called, you need to document what you are doing. So here is an example of the document they are proposing. But you may adapt these documents to your local protocols. But really, the summary of what is on the paper is why was the team called, when the team arrived, and then what were the early warning signs. And those are arranged relate to the A, B, C, D. So what are the respiratory issues, airway issues, cardiovascular issues like low blood pressure, neurologic, like any seizure, loss of consciousness. So all the things we do, and then sepsis because it's a common issue as well. And after that, you can go down and see your response. What did you do? If the patient had respiratory failure, what kind of intervention did you do? What were the vital signs? So that you can measure your response and evaluate progress, evaluate improvement over time. But also this can help to have a debriefing. You can see what you did well, what you can improve. So I don't know if it's clear, or if there's any question or any addition from Ale or Jean-Paul, it's welcome. Yeah, but again, my take home is who should be on the team. It means it may be a doctor, maybe a nurse, pharmacist, respiratory therapist, whenever available. And then you need to have people who would activate the team. So the nurse taking care of the patient, you have the next of kin, and you have the patient himself. And then you have to have a good communication system, and then a supporting system from the administration. That can be a clinical director, chief of nursing, the head of the hospital, and then you can also have the quality improvement officer, which can help to do the evaluation of the project. And if you started the program, I think me and Jean-Paul and Alain will be also happy to support the project. So any addition, Alain or Jean-Paul?
Yeah, just coming back on our experience in our hospital, I would like more to insist more on administration, because having people able to do things is a good thing, but the support is so needed. So a small comment on what's happened in our hospital. It's like we are having everything, but one policy was blocking us to do a good job and to access on things. So we went to the administration and exposed our issue. And normally to change a policy, it can take more than 1 month or 2 months. But as it was something needed and the administration was supportive, it has been changed like in few days. So I found that this support from them is so important, and it has helped us to make our job more easy. That's why I'm saying that to have people able to do things is one thing, but the administration must be supportive.
Okay, I have a follow-up question. So
Yeah.
So first, what do you think is the most support needed from the administration? And the second question, how do you recruit people on the team? How do you train them? How do you make sure there is a schedule for every day and the weekend and the night?
So first, I'd like to start by what was available before this pandemic. So let's take 2 years prior to COVID. Maybe there was a resuscitation team, which was headed by someone who was well trained, and he was making sure that every 3 months or 2 months there was a kind of refresher, and everyone was trained. But once this pandemic came, we found that the station team was a bit small. So there was a thought that the hospital can't manage everything by itself. So that's why the rapid response team was created, involving many stakeholders from upper to down. So some of them were also, of course, clinicians, and others were pulled from other spaces, as you said, pharmacists or people outside of even medicine. So the first thing they did, because it was a kind of emergency, it was to make sure that everyone is aware of what's happening. making sure that if I found something, I will be able to transmit the message at the same time to those deciders, those people are able to decide. So they install a system of communication which was at really easy and accessible to everyone in the team. So to about recruitment of people, some people came from the station team, some people came from the administration. Of course, those people who are already aware of what was happening and seeing the situation as a global thing. And so the team is composed of the people who are deciding, in administration, even people out of the hospital. And there is some people pulled from the station team, and there is a system of communication, which I found so easy because it doesn't need it's a kind of CUG, so everyone is able to talk to everyone, and there's our society, we used to have this issue for hierarchy. You can talk to a superior person as you want, but in the rapid response team, even someone who used to be called small is able to talk straight away to the someone who is more senior, or the chief of the chief. So it is easing our job. That's how I found that rapid response team was created. Maybe I'm not sure if I responded to your question, Eugene.
Yeah, thank you. The last question is about the schedule. So because we have few anesthesiologists, for example, you may have few critical care nurses. So how do you manage the schedule so that there is someone available to respond to the activation of the team while covering the rest of the hospital?
We have people who are responsible of that, but they make sure that at any time there should be someone coordinating the team every day. And if even during weekend, it is always covered. So there's a kind of continuity. I agree it can ask maybe more people to help, but this continuity system brought an idea of being accountable. So there is also a kind of giving reports. So reports are given every day. So there's no, we can't say that there is a day without controlling what's happening. So we have people who are on the team. They make sure that we are aware if they need us or if they're using the other side of emergency. So there's no, we always have a kind of continuity. I agree it's a bit heavy, but it is helping.
Yeah, thank you. So just my comment, knowing the situation of a district hospital as an example. So I imagine a rapid response system, including, for example, you will have like a GP who is like covering the emergency department, or another GP covering the obstetric department. And then that GP can be called for all obstetrics like activation. And then also you have one anesthetist who will be there on the schedule, knowing if there's a rapid response team, she will be called to go. And maybe you would have like most of the equipment put in one cart for each department. Each department should have like one cart with all the emergencies and equipment needed. And then you will have also a nurse in that particular department who would call the rapid response team. And then she will see like you have an anesthetist who is there for airway. You have a GP who will provide also the leadership for the team. And then together, I think you can start small, and then you can learn from your experience as you go. Jean-Paul, are there any additional comments before we continue to the last slide?
No comment, and I agree with what you say. We have to start small.
My comment or my addition is I'm supporting
Yeah, Jean-Paul, go ahead. Jean-Paul, we can't hear you.
I was saying that I'm supporting what you have been discussing, what Ale came to explain. Just this rapid response team is needed wherever is not available before. It's a time for all of us to start thinking about it. And the key component, as I said, is to have administration support. That's one. And to get the administration support, most of the time we should have this the convincing point. You present the idea or the activity that you want to introduce in the system, in the hospital or in the institution. But most of the time they ask you, what are the news from the existing? What are the novel? What are the innovation from the existing system, especially in the existing system, all of the hospital, they have a resuscitation team and committees. So by introducing this one, you have to have a convincing point from the study, the articles you have been reading about it. That also should be another supporting point. I'm inviting all of my colleagues who are attending this course, including me, that we have all the evidences that we should start with. Yeah, that's my comment.
Okay, thank you. Yeah, we can go to the next slide. Yeah, so thank you. So let's talk about the implementation. So the framework to use during the implementation include the situation, evaluation of the situation, decision making, and then some of actions. So let's go down and see the practice change we are looking for. So for the situation, we need to see the rapid response system, if the rapid response system may improve patient outcomes. We know that the rapid response system may identify warning signs before respiratory or cardiac arrest, because that's the goal. So and the rapid response system provide timely critical care to unstable patients. That's the situation. And our evaluation is that creating or review of the rapid response team policy at our institution is important. So in order to do that, we need to identify key stakeholders, which may include patients, nurses, physicians, families, pharmacists, respiratory therapists, and doctors. So we need to identify barriers. And some of the barriers we discussed may include lack of enough equipment and drugs, lack of enough team, and the lack of some expertise. So the decision, we may consider forming a rapid response team committee, which can work with the respiratory, it may work with the resuscitation team committee already. So we need to ensure that the key stakeholder perspectives are represented. Establish a timeline within which we can start or make some changes. We may think about how to identify solutions to barriers. Actions, we need to think about how to adapt existing protocols and to ensure schedule the review to address barriers and improve patient safety. So before we finish, I would like to ask Alain his experience. what are the common barriers do you anticipate while someone is developing like a rapid response team in his hospital?
Hello. So barriers, because it was our first experience, so maybe I will talk about what I saw in our hospital. First is to, as you said, having everyone the same boat, and not knowing that everyone should be involved and understanding why we are doing something. So first is to understand the situation where we are and if it is needed. So if we understand where this situation, it is easy. Of course, we have to get people who are decision maker inside of the group. They have to feel that they are needed as clinician or other people who are working on the field. So to know the situation of where we are, making sure that decision makers are part and they feel that they are really needed. And of course, making sure that each department has a representative. I saw that maybe sometimes if we talk about a rapid response team, maybe people can think about anesthesia, emergency, but a hospital is a big thing. Even an issue can happen in those administration blocks. So everyone should be involved. If we have a representative of each department, is so important, and it helps. How it helps also inside of each department, maybe pediatric, be sure that they have needed materials, because once we are called, sometimes it's a bit tricky to have everything with you. But if you know that you've been working with everyone and you are able to get what you need where you are going, it's easy. So materials, decision maker, understanding the situation of where you are and what is available and what can be availed is among the what I saw as in our experience. I found them so helpful to build this kind of team.
Thank you, Alain. So we can go to the next. Yes, right. So here is the summary of the implementation steps. So create a rapid response policy document for the institution, defining the rapid response team, defining the purpose of the policy, defining who can activate the rapid response team, create and the alert criteria, triggers or parameters used for the rapid response team policy, define your procedure for activating the rapid response team, who calls, how do they call, who respond, who are the members of the rapid response team, what expertise do they bring. So remember that now every hospital is required to have personnel trained in the BLS and the ACLS. I think that's a good start where you can ask for more support in equipment and the drugs. But also you can work with the quality improvement officer to have evidence of the current practice and the current outcomes of people requiring resuscitation. And then if you can show some gaps, that can be also used for advocacy for more support in the creation of the rapid response team. So define the roles for each of the rapid response team members, what roles are needed, and who will perform tasks. So for most of our team members in this course are anesthesia providers, so we will be expert in airway, but also in resuscitation. And I encourage people to train others, because once you have more people trained, the work become easier. So consider common causes of rapid response team activation, including airway management, blood pressure support, cardiac dysarrhythmia, overdose, especially like opioid overdose, hypoxemia, hypoglycemia, altered mental status. Communication with family, this is important part of the rapid response team. Define the supply and equipment that need to be brought, medications, IV supplies, lab tubes, documentation, defibrillator, airway equipment, define the disposition for the patient, including a stabilized and stay in the ward, move to ICU, or transfer to high level of care. Actually, we need to think about a safe transfer of patient. Which equipment do we need? What kind of monitors? Who should go with the patient? Which communication do we have to have with the receiving hospital? All those things need to be thought about. And we need also to be able to measure progress and improvement. So among the disposition, some of the people, of course, will have poor outcomes and may die. So those are the steps for implementation. And I think this is a good summary and a guide for someone who is interested to start the rapid response team. So we can continue. So before we go to the key learning point, maybe you can have like 5 minutes in the breakout rooms for people to discuss about take-home message. So I can have one team, and example we have another team and Aaron. So we have just 5 minutes, and after that we come and conclude. Alan, are you okay to divide us in 3 groups?
Yep, it'll open in just a moment.
Perfect, thank you.
Wait, mwatubwiye amakuru y'ukuntu mwitwara iwanyu? Mufite ibiki? What do you have? Just share with us your experience. It is really needed. We want to know what you do. What do you do? How is it, Fidel? Muhire? Hello. Is there anyone who? Yes, Muhire. Or Tikanga Diodone? Would you share with us your experience? Hello. Hello. It's an open discussion. Yasent, what do you think? Yasent?
Yes.
What do you think? Yes. What do you think? We've been talking about the rapid response team, and I know you have, you know it very well more than. What do you think? What can we do differently, or how can we insert this in our different hospitals according to what we have?
Okay. Njyewe murira CHK ndavuga ibijyanye na CHK. Iriya rapid response team bagerageje kuyitandukanya gato na resuscitation team, ariko no mu bitaro byacu igikora ni resuscitation team. Usanga rero hari komite n'abayigize. Yeah. hari nimero ahantu hose, hari alarms, igihe habaye ikibazo hari alarms ugasona, hanyuma abantu benshi bagahita baza bakagufasha, iyo timu ikaba motive. Ariko icyo ntekereza iyo timu, iyo habaye nk'ikibazo, ubwo ndavuga cyane cyane nka sale dope kuko ariho aba NPAs tubarizwa, usanga iyo habaye nk'ikibazo rimwe na rimwe gikemurwa nko mu kajagari. Ubwo nshatse kuvuga ko muri kunyumva?
Turakumva cyane.
Iyo habaye nk'ikibazo muri sale dope, ni urugero kuko niho nkorera, nabonye bisa n'ibikemurwa mu kajagari. Iyo timu irakora n'ibyo, ariko ntabwo wenda nyuma niba yabaye mobilize iyo timu, habayemo ikibazo basabye help, usanga nyuma ku ma emergency trolley, ziriya forms zo kuzuza, wajya gukora monthly report yo resuscitation cases zabaye, ugasanga ziriya form nta na kamwe kuzuye. Ukibaza ukwezi kumwe, abiri, atatu, ni ukuvuga ko aha hantu nta kintu bakoze. Akenshi usanga barakora ariko ari amafomu agomba kugaragaza ibyakozwe, ndetse akaba evidences mu ma improvement, ntabwo akunda kuzuzwa, yuzuzwa n'abantu bake. Rimwe na rimwe niba habaye nk'akayensida, ugasanga wenda abantu ntibanashaka ko kamenyekana, ntibanashaka kukadokimanta ibyo bakoze, ugasanga birangiriye hagati y'abantu ku giti cyabo.
Ndabona Dieudonné microphone yari ifunguye, sinzi ko yadufasha kuduha umucyo, cyangwa undi turi kumwe akatubwira ukuntu nabo bakoze. Yego, hello, it's an open discussion. Undi ufite kutubwiye ko wabiteguye, ukuntu afite resuscitation team, ukuntu maybe bagiye bitegura na covid, bakagira group iri unlarge, irimo n'abandi bantu bose guhera kuri gate. Sinzi ikintu yatubwira. Yego, Fidel, hari umuntu kugerageza niba. Yego, hello, mutubwire nta kibazo. Musanzu yase ukuntu niki twafasha abandi dukurikije experience tumaze kugira muri ibitaro byacu, kugira ngo nabo bagere aho bagera gato, to sharing experience ibintu biri feasible.
Okay, so welcome everyone to the main session. So I'm going to summarize what we discussed, which is not much, and I don't know what it means. I will have like 2 minutes, and Ale will have a few minutes, and Jean-Paul to say what they discussed. So in our group, people were very quiet, but at least Coppens discussed about the challenge in training. So how is the team trained? Who is trained? So, and he was suggesting that all people or clinical staff should be trained in the basic life support and the ACLS. So because he think people were trained included administration and only doctors. So we need a multidisciplinary team training. That was the take-home point for him. But also we need to train people in the difference or the importance or the use of the rapid response team and the cessation teams. So we need to provide that information or present that knowledge to the administration and the clinical personnel about the need and the use of the rapid response team and the cessation teams. So we need to show evidence of that. I think those were the two main points. So people also wrote in the chat. So people are just writing in the chat, but I don't think there is much, something different there. So yeah, I think that's it in our team. I don't know if people understood what we discussed, or it was because of the internet, because people are very quiet. But at least those are the two take-home points. I can let Jean-Paul discuss about the take-home points, and then Are will finish.
In my team, I experienced a similar problem or challenge you got. My participants were quiet. I don't know if it was the problem of maybe internet, or if they were not hearing me well. I don't know, but one participant is the one who mentioned that this rapid response team is needed in the hospital as like a key home message. And that one participant who mentioned this, in order to avoid this, because people were quiet, I have been emphasizing about this quick sofa, where I highlighted that in a patient who is in sepsis or in a septic condition, we need to focalize the three systems: CNS, respiratory, and cardiovascular. That's and any change from CNS, any change from cardiovascular, any change from respiratory, in terms of GCS, in terms of blood pressure, and in terms of respiration, these are the warning sign, and which will correlate to mortality. At any time you delay to take an action or an decision, it will end up with the study have found that it is associated to the mortality rate. This is what, in summary, what I've been discussing in my group. And thank you to Claudia who gave us this key home message.
Okay, thank you. Let's hear from Alain.
Thank you. In our team, we got the opportunity to be to get a clear. Just one of our participants helped us to see what is done in her hospital. So she reported that there is an issue of reporting issue, especially things are done but not reported. So the resuscitation team is doing a great job, but sometimes there's a big issue of reporting. Those forms of resuscitation are not completed. Another issue reported was about also keeping the material in a good way and working and replacing what was used. Sometimes it seems that some of our materials are not well checked, and sometimes you find maybe a defibrillator with that good battery or which is not functional, and you can find it there but not working well. And also she mentioned that we have to try to make this resuscitation more bigger and try to find people from different places to make it as a rapid response team. As nowadays we have this pandemic, we need to have the administrative people supporting. That was her take home message.
Excellent, excellent. I think those are good. So we can go to the last slide and for conclusion. Yeah, so here are the key learning points, and we'll see if we covered all of them. So the critical care is a continuum and is not limited to care inside an ICU. That's point one. So point two, oxygen should be provided until the SpO2 reaches 96% and not above. So point three, used in patients outside of an ICU, quick SOFA above 2 indicates further investigation and closer monitoring of patients with suspect infection. Point four, patients with a high modified early warning sign score should be considered for transfer to a high level of care. So point five, quick COVID Severity Index predicts the 24 hours risk of critical respiratory illness in a patient admitted from ED with COVID-19. Point six, rapid response team bring timely critical care and expertise to patients who are unstable. Point seven, so activators of the rapid response team can be anyone, including the nurses, doctors, the patient, and the family members. Point eight, respondent to calls of rapid response team should offer expertise in resuscitation and evaluate for increased level of care. Respondent can include nurses, doctors, airway experts, pharmacists, phlebotomists, respiratory therapists, transporters, and others. Point nine, the rapid response system, different from the rapid response team, requires the support of administrators and the quality improvement personnel. And the last point is, through documentation during a rapid response team, ensures an appropriate patient care and a good communication during transfers of patient care. So those were the take-home points. So I thank you very much for your attendance and also the participation. So before we close, maybe Arana can explain to you the ways you will get your certificates and the CPDs. So again, thank you very much.
Great, thank you everyone. So to wrap up the session, just want to remind you that the Learning Resource Center is a great place to sign up for, because you can get access to the module that was just presented, as well as the recordings, additional resources, quizzes, case exercises, and videos. So you can sign up on there, and I'll share the link in the chat and the WhatsApp groups. And we'll also share the recording and access to this after the session as well. We have a group on WhatsApp that you can join by either scanning the QR code on the screen here, or you can message me, assist at the number indicated on the slide. So for certificates, if you were present at sessions 1, 2, 3, or today's session number 4, you will receive an email to receive a certificate of attendance that looks something like this. The way that it'll work is that you'll just simply have to input your name and the session number, and you'll get a printout of the certificate automatically. If you do not receive a link to get your certificate within the next week, please message the WhatsApp group or email me, and I'll put my email in the chat, and we will sort that out for you. And so the email is on the screen there. And then the last note I have before we close out is that please save in your calendar session 5. The topic will be critical care outside the ICU. And sorry, the date's not there, but I can say it here. The date will be May 29th, Saturday, May 29th.
Oh, Alana, we have covered this topic today, so we'll send them the topic.
Oh, yes.
Yeah, for the next.
Yes, sure. Yeah, I think we may have skipped the topic, but yeah, we will correct that on the messaging. But yeah, thank you for that. And I see someone has shared their WhatsApp number. If you're also welcome to do that, and I will add you to the group. But just to end the session, thank you to Dr. Eugene and all of our panelists for sharing all of this information. And we hope to see you next month.
So thank you very much.